Hi, Sandra. I'm Emmanuel. I'm one of the doctors from the surgery.
Hello.
Hi. Yeah, hi, Sandra. How are you doing today?
I'm good.
Right, right. So how can I help you today, Sandra?
Right. I'll get straight to the point, doctor.
Hmm.
I've been having some discomfort down there, and I noticed it has been harder to have sex. It's uncomfortable, and I've been feeling a bit off lately.
Hmm. Oh, bless you, Sandra. Could you tell, could you walk me through what exactly has happened before you started having the symptoms and then afterwards?
Oh, okay. I've been having some issues down there, like vaginal dryness and itching.
Mhm.
It's been uncomfortable during sex, and I also noticed that I've had to, go to the bathroom more often, and I feel like I'm in a rush to get there.
Right,
These symptoms have been going on for a few months now. I've recently gone through menopause and haven't had a period for about a year. I don't have any major health problem, but just mild cramps while I was younger, but nothing that I've needed treatment for.
right.
But lately, I noticed that I've been feeling more tired than usual, and honestly, I've been feeling a bit down about these changes happening to my body.
Oh, oh. Sandra, sounds like a lot has actually been going on. And with all of this going on, I hear you mentioned about it's in menopause last year. Have you given any thoughts as to what perhaps might be going on?
I think it might just be because of the menopause, but I'm not really sure. I've
Mhm.
read that estrogen might help.
Oh, right, right, okay. Where did you read that from?
Just something I got online.
Oh, online, right, right, right. So, what did you read about estrogen helping?
Um, I don't. Just some general about helping with the dryness and itching.
Right, right, right. Okay, that's good, Sandra. Actually checking some of the symptoms, right? You doing that is really good. Is really good. And I hear you mentioned estrogen. Is that what you were hoping for from this consultation, or did you have something else in mind as well?
Yeah, but I'm really worried about the estrogen because my aunt had breast cancer, and I don't
Hmm.
want things to get worse for myself.
Right, right. So sorry to hear about your aunt. How's she doing?
She's late.
Oh, oh, okay. And with that information, what you've read with estrogen, breast cancer, how has that made you feel?
Sorry, what did you say?
How has it made you feel? What you've read with estrogen and then the breast cancer?
I'm just worried about it.
Right, 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 right. Okay, and that can be expected, and I will definitely address that going forward. Apart from the estrogen, is there any other thing you were hoping for from this consultation?
Yeah, I just want to know if this can be fixed because it's having such an impact on me and my relationship, and I feel like I can't ignore it anymore.
Oh, right. You mentioned your relationship. Could you tell me what you mean? How it's affecting your relationship?
In the sense of the sex life, like
Yes.
I'm really uncomfortable
Right,
during sex.
right. And is your partner supportive?
Yeah, yeah, it's been.
Right, right, right. Okay. Um, besides your partner, is there anyone else at home with you?
No.
Right, right, right. Okay. So I'm going to check with you a bit of the other symptoms that one might expect, right? And try to see how that might be impacting your day to day. Have you noticed perhaps any changes to your mood?
No?
Right, right. Do you sometimes get hot flushes?
No.
Right, right, right. You mentioned that you've not had your periods in a year. As have you noticed bleeding down below at all in the past year?
No.
Right, right, okay. Um, because this is also quite important. Do you drink alcohol? Do you drink alcohol?
Yeah, I do
Right,
occasionally.
occasionally. How much do you drink?
Just a few bottles, just
If
not
you
much of a drinker.
not much of a drinker. A few bottles. Do you mean how often? Is it once a week or every week?
Every week.
Every week, right? Do you know the number of units you drink per week?
I can't remember.
Right. Okay. Um, do you smoke?
No.
Right. Right. And how's your usual day to day like? I mean, work, exercise. How's that like?
I because of these, I kind of feel have this self-conscious and I'm anxious about mostly about my intimacy with my partner.
Right.
Because yeah, I just feel a bit down about it. Then
Oh,
my social life, it's kind of reduced my sexual activity due to the discomfort.
mhm.
Um, I have a moderate physical activity,
Right.
and yeah.
Okay. Okay. Right, Sandra. Lastly, to check with you, some other slightly sensitive questions. Have you noticed any discharge down below?
No.
Right. Right. You mentioned you have a partner. Have you had any other partners within the past, say, 1 year?
I've been married for 25 years.
Right. Right. Okay. Okay. Right. Thank you for that, Sandra. So, I hear you mentioned about considering this might be menopause, and you were wondering if this could be fixed. You've considered estrogen, and if this could affect in any way with breast cancer, as that happened with your aunt. You're quite concerned about the vaginal dryness and itching. You're using the bathroom more often, and it's affecting intercourse as well. And you were hoping to get all this fixed.
Yeah.
Right. Okay. Now, Sandra, let's find ways to help you. First, based off the symptoms you have, it paints a picture of, yes, what you mentioned, menopause, right? And I understand you've read quite a bit about it. It's happened over 1 year, right? It's called a change sometimes, and some of these things that you've described are the changes that might occur in women,
Okay.
right? And I mean, having celebrated 52 years of life, it is not uncommon to have this change, Sandra.
Okay.
And the good thing is there are loads of ways we can help you.
Okay.
Right? Do you have any questions for me, Sandra?
No.
Right. Okay. So there are a few options we can explore. That would be using hormones to try and make this better, because essentially the menopause is a bit of imbalance in the hormones, right, produced in the woman's body. We can use other hormones to take care of it. One of them is the estrogen that you suggested, or there are other options that do not have hormones in them,
Okay.
right? Do, I hear you mentioned about estrogen. Are
Mm.
you Do you want me to focus more on that?
Yeah, I would love that, but we have a family history of breast cancer with my aunt.
Right,
Yeah.
right. So yes, with your aunt, apart from your aunt, have you had any history of cancers at all?
No.
Right, any histories with blood clots?
No.
Right. Okay. So yes, with the history with your aunt, right, that can have an impact as well. But I'm not too sure at this point if that will totally mean you cannot use hormone replacement.
Okay.
Right. So with the hormone replacement, I see from your notes that you've not had surgeries before.
No, I haven't.
Right. Yeah. So there are options we can consider. We can consider pills, we can consider patches or gels, or or we can consider using a rod as well, which or a coil, pardon me. Do you have any preference?
No.
Right. So we can explore using a combination of the two hormones, right, and getting them balanced, right, and replacing them essentially, right. Do you have any particular? Do you have any questions you want to ask me at this point?
No.
Right. Okay. So yes, I can the estrogen you mentioned, right?
Yeah.
I can prescribe to you a patch that has both estrogen and progesterone, right? Which you can apply to your skin, and then it will be absorbed into your body. It has less risks of a blood clot.
Okay.
Yes, so I can get that prescribed to you, and then if you have any irritation, do let us know.
Okay.
Thank you. Yes. Thank you, Dr. Ima, for doing this case. Well done.
Yeah, yeah.
There are definitely some positives that you've done, and I'm glad you've done this case so that we can really iron out the things that need to be worked on. So before I ask Dr. Chogo to give feedback and discuss how we manage this case, I just want to get your insight about what you think about these patients, about the case itself.
Yes. So I think I was trying a bit of balance by
The
breast
bluntness.
cancer. What?
Okay.
the breast
Go ahead.
cancer
Yeah.
in the first degree relative, I'm not too sure if it is an absolute contraindication or not. I'm not too sure. So I kept thinking, should I go hormonal or non-hormonal? But I knew I needed to commit to something.
I see.
Yeah, so, but because she had multiple symptoms, right, I was thinking it should be hormonal, but I wasn't sure how that estrogen. Yeah.
Okay. So what's your diagnosis in this case?
Menopause. But I know she has that diagnosis already, though.
You like give a
Thinking
clue
about it again.
Okay. Anybody in the chat? Let's see what the group thinks, because there is a common thing. Okay, SAGUS.
Yeah.
Bear with me. GUS is not clicking for me right now. I probably need to drink some water. Thank you, Precious. Vaginal atrophy. Atrophic vaginitis.
Yeah, that's
menopause.
genitourinary syndrome of menopause. That's what it is.
Okay. That wasn't clicking. Somebody said vaginitis. I know that's supposed to be a V. Okay, well done. I just wanted to see if others were on board with this as well. So yes, atrophic vaginitis. And here, I think, Ima, is one of the things that you need to consider.
Yeah.
The most common presentation and the most common thing we do is the simple menopause. Menopause patient is just coming in. Menopause patient wants review. But what about menopause with other components? We keep missing those things, those extra bits. And this exam is expanding. The exam can bring in any forms of menopause. So yes, you're thinking menopause, but a part of me was like, is he managing general menopause or is he managing something very specific? Because this is very specific to the patient. But I actually thought you were even put off by the lady's bluntness. Because yeah, some people might be, because the lady just comes in, doctor, I'm straight to the point. And they start to tell you, it's affecting sex, she's using all those words, and some people will be on edge about such bluntness. This is where Dr. Chogu said, be comfortable with having this conversation, because you might meet a very blunt patient who is ready to tell you every sexual problem they are going through. And then you might meet a patient who is embarrassed and they may not be willing to disclose. So consultation skills and our competency as doctor requires us to know how to manage the different types of patients that come into our GP surgery. I hope that helps. So yes, the diagnosis is atrophic vaginitis. I will then hand over to you. I was going to say, if you think about this case now that you know the diagnosis, what do you think you would do different?
Right. Actually, when I would top my patient's agenda, as I was speaking to the patient, I would vaginal dryness, bathroom more often, sexual activity. So I knew I wanted to address that. Right. And I was initially at the outset, I was thinking I would probably go non-hormonal, give advice to use lubrication, test for UTI, my investigations would be to test for UTI. My recommendations would be lubrication, since this was beginning to affect the family. Did they need a bit of counseling as well? Those are some of the things that went through my mind. But I'm not too sure if I'm very familiar with the management, with the details of management. Yeah.
So you're identifying a learning need there, and I hope you go back to your nice CKS and revise about management of different aspects of menopause. So before we hand over to Dr. Chogu, I think this is something I discussed in a particular weekly tutorial in the general group at the time. When you see a patient coming menopause, so a patient comes in and says, Doctor, I've got all flushes, whatever. What are the three components of menopause we need to be assessing? GUS is one of them. What are the other ones? Anybody in the chat? Mood and irritability, so the cycle. Vasomotor is one, yes.
That's the number one.
Urinary syndromes, and then the mental, psychological impact of menopause. And that's me just giving you a clue to have robust management. Okay, so yes, mood is part of the psychological, because it may not just be feeling depressed or weepy. It might be having irritable. It might be affecting, that irritability may affecting relationships. So when you see one patient coming with one aspect of menopausal symptoms, you have to be asking for other aspects as well. Okay. All right. So we're going to hand over to Dr. Chogu to give us feedback regarding this case. Hello, Dr. Chogu.
Hi. Yes. So thank you for volunteering, and I'm hoping that at the end of today you'll go and do some reading on the menopause. It's such a huge topic and so topical at the moment that you can't miss menopause. Okay. Because so many women are saying, my doctor is not answering me, my doctor is not this, my doctor is not that. So at the beginning, when she said, oh, I'm having issues with sex, your response was to say, bless you, Sandra. So it may be more appropriate to say, oh, it looks like you've been struggling a bit with this.
Okay.
For a woman to come and tell you that she's struggling with sex, it has reached a very, 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 very serious point. That's why she has come. Most women will not come and tell you about that. So you have to you need to recognize that it is quite a difficult topic to talk about. And for the woman to come and tell you like that, it means she suffered a lot with it. I like how you said she should walk you through the symptoms. That was excellent. Then she gave you all the story and you said, oh, sounds like a lot has been going on. Another thing that was evident throughout is you use so many words to communicate what you want to say, which is one thing that IMGs we have as well. The simple question when she said, I've heard that estrogen might help. My response to that would be, yes, you are right that estrogen can help. Was that what you were expecting today? I'll just jump straight in and get expectation there. Or you use like 3 sentences before we go to, was that what you were hoping for today? You know that estrogen can help. She has read that estrogen can help. So you just affirm that and then ask the next question. And then she said, oh, my auntie had breast cancer, so I'm worried. The next question there is, oh, how old was your aunt? Oh, you did well by asking about how she's doing. And she said she was fine. Okay, so how old was your aunt when she had the breast cancer? Is this your auntie from your mother's side or your father's side? Because we know that it is the maternal aspect of breast cancer that we're more concerned about, not the paternal. How old was she? Did she take HRT? Was she obese? There are other things that can cause breast cancer. It's not HRT alone or estrogen alone that causes breast cancer. We know several women who do not take HRT who have breast cancer. So another thing you're going to go home to read today as well for everyone is the breast cancer risk on the NICE care. Then you asked her how it made her feel about estrogen and breast cancer. No, the question here is how has this dryness and having to pass urine and it will have effect on her relationship, have effect on her life. That's where you are going for the impact. Imagine what work does she do? If she's doing some work that needs her to be sitting at a table for a long time, or she has to have several meetings, and then she's going to pass urine every time, that can be very, very stressful on somebody's life. So that's the patient journey that I was alluding to in the beginning. How is this affecting this woman? Of course, we already know it's affecting her family life. And now she's passing urine frequently. So how is she working? We don't know what work she's doing because that would have shown more of your relating to others here. You said it was affecting her relationship. That was it. It would have been easier to come or more appropriate to come in and say, "Oh, this must be quite difficult with regards to the dryness. How has your husband found this?" And then you can also ask, "What has she tried?" Because before patient come to meet you, they must have tried things. Has she tried any lubricants? Has she tried anything? So that it tells you to tailor your management. Then there's a lot of right in your consultation. So you need to try and remove that. I had that a lot as well. I used to say right, and my husband had to tell me this right is not making sense. It's not sounding okay. So I removed that as part of it. You need to try. And then you started by saying, because it is you now signposted to questions you wanted to ask. There's not that wasted some more words as well. So if I want to ask these questions, I start by saying, being that you've had this dryness and passing urine more frequently, in the past years since you stopped your periods, have you had any issues with sweating at night, sweating during the day, any issues with brain fog? Have you had any problems with concentration? Are you experiencing any joint pains? Or you take one symptom from each of those 4 categories that Christina has said, the cognition, the vasomotor symptoms, which is present in 80% of women, then the mood lability, it can be anxiety, it can be irritability, it can be depression. There's a lot of mood issues, then the cognition part of things, and then the other non-specific things, palpitations and joint pains. So just take 1 or 2 of those things. That's when you now take the history. Then there was no history of fever here. She's going to pass urine more frequently. Does she have a UTI? So you use so many words, so you didn't get enough data to come to a diagnosis here that this is genitourinary syndrome of menopause or atrophic vaginitis. But a more appropriate diagnosis is the genitourinary syndrome of the menopause. Because when you say atrophic vaginitis, it's just the vagina, but there are estrogen receptors in the whole genital tract as well as other parts of the body. So it is the lack of estrogen that is also causing the irritation in the vaginal tract. And then you now asked about vaginal discharge. If she had other partners, that's asking about other partners made it worse. That just dropped your relating to others by far because you saw that she was not irritated and said, I've been married for 25 years. There was no need to ask about other partners here. She has not come to tell you that she has vaginal discharge, you know. Instead of asking this, it would have been better to ask about if she has used any lubricants, if she has used any other things. And has she had pap smears? That history was not there. There was then the breast cancer again. You brought it up that it happened with her aunt, and you didn't risk assess to see whether this breast cancer is a thing that is really important in this patient. Please, can the patient, the actor, can you tell us how old was your auntie when she had the breast cancer? Is that in the history? Then you now said, now Sandra, let's find ways to help you. That sounded very patronizing to a British person. So I would say, yeah, yes, from speaking to you, because you did not have a working diagnosis. So when I was preparing for my exam, it was RCA then, we had topics, there was this traffic light system we used. So you had to state, when you are going to clinical management, you have to state the diagnosis. You have to state your working diagnosis. So from speaking to you, Sandra, it is true that you are in menopause because it's more than 1 year since your last menstrual period. And sometimes as part of the menopause, many women experience what is called atrophic vaginitis or genitourinary syndrome of the menopause, which appears as what is happening with you. And this happens because there's low or no estrogen. And because there's not enough estrogen, there's reduced moisturization in the vagina and the genital tract, and that's what causes you to want to go past urine more frequently. It will be very useful for us to have a urine sample just to make sure that there is no urine infection going on that we need to treat. I know you had concerns about estrogen, but the estrogen that we usually use to treat vaginal atrophy or atrophic vaginitis or GUSM is a very low dose, and it usually stays around the vagina. So there are two different options. We can give you a pessary or a gel, and alternatively as well, we can give you a vaginal moisturizer. Would you prefer to use the moisturizer in the first instance and see how you feel about it? Or would you want to use the estrogen cream? There's the risk for you having breast cancer from this vaginal estrogen is minimal. It is almost non-existent because you're not taking, it's not going to be absorbed inside the bloodstream. It's staying around the vagina. The amount that is absorbed in your bloodstream is very, very tiny. In fact, using this vaginal estrogen every day for 1 year is equivalent to taking 1 contraceptive pill. That is how low the dose is. So you do not address this patient's concerns of breast cancer and vaginal estrogen. And that should be your first, after you've made your working diagnosis, your next statement is to address the patient's concerns and expectations. So that was missing here. So vaginal moisturizers, because we don't know what this woman has used before, it's difficult to give advice. But there are many vaginal moisturizers in the market. She can use Hyalofem. She can use Yes Vaginal Moisturizer. She can use Replens, which is also a moisturizer. She can also use coconut oil, pure coconut oil, as a moisturizer. And then when you're telling her about the vaginal estrogen, you have to be clear, because in your discussion of medications, you started telling about pills, patches, gels, and coil. It was something like a contraceptive discussion and not HRT discussion. So this woman does not have systemic symptoms really of HRT, of menopause. She's having more of a localized issue with the menopause. And while she will benefit from HRT in this case, being that the main issue here is the vagina and the genital tract, you can focus on that, send her more information and see if she wants to discuss HRT because she has osteopenia. So HRT is not a prevention for osteopenia, but it can help. So that is by the way, okay? So here, your management should be, there's a cream, which do you prefer? If she prefers Ovestin, that's fine. If she prefers Vagifem, that's fine. But whichever one she prefers, she will need to use it every day for 2 weeks as the loading dose. And then thereafter, she'll use it twice a week, insertion into the vagina, twice a week. Would you be happy to bring a urine sample to the clinic just so that we make sure that there is no urine infection that we need to treat as well? And then that would be your management plan. Then again, you talked about the less risk of a blood clot. This patient is not worried about a blood clot. There is no risk assessment here that talks about a blood clot. So if the examiner is listening, they will say, why have you got, because I said, why are you bringing blood clot here now? And then there was no discussion about how she would take the medication. So when you want to give a patient a clinical management, start with a working diagnosis, address their concerns and expectations, and explain how to take the medication. So this was not really here today. and menopause can be very, very daunting, So just go back, do a little bit of reading on it. Nice CKS, go to, and someone is talking about getting Relate as part of holistic clinical management. Yeah, you can do that. But the issue is what needs to be done is to treat the organic reason. She said her husband is supportive. So yeah, you can also give resources. Menopause Matters, Rock My Menopause, as something to also share with her husband to have a read about. Because sometimes the husband do not know that the wife, this is what she's going through, and may not understand. And in all this as well, you didn't ask the patient about her libido. Is she even interested in the sex at all? So the history of the menopause was not there. And then the history around this vaginal atrophic vaginitis was a bit clunky as well, and used so many words. But it's a very, very good first attempt. I'm hoping now that you're going to create scenarios for yourself. Make what I used to do there, and I still tell people, is to get a piece of paper and create different scenarios of the patient journey in menopause, like I said in the presentation earlier, and go from there. Does anyone have any questions? Thank you for trying, Dr. Motosho.
Thank you. Thank you, Chloe. I'm not just familiar with atrophic vaginitis at all, so I rambled a lot.
Yes.
Thank you for that. It helps clear it up. Thank you.
And this is normal with male trainees. It's so difficult because you are not seeing it. So you have to put in that extra effort to get the information about women's health.
Thank you.
Yeah. Thank you. Thank you for the feedback, Dr. Chogo. And this is where we are trying to get you to see different cases around a particular topic. So we know that menopause presents in different ways, and that you can go back and study the other parts. Because if this same patient can come back and talk about how much it's affecting her mental health and tell you, as a follow-up that, oh, thank you, the cream you gave me last time for down below was working, but now she's probably talking about something that's maybe the mental health or relationship issues that's happening. And this is where we need to study different aspects and ensure we know robust management for different aspects of any condition. So we've written here a summary of some of the things we want you to think about when doing a case like this. We want you to think about the physical impact. So the limitation in this case, because it's genitourinary syndrome of menopause, the physical limitation will be her sexual health and sexual relationship with her relative. Thinking about the emotional impact and her overall well-being. And if you're just only focusing on that clinical symptom the patient is presenting with, you'll be losing mark in that case. So a clear pass candidate would always have robust data gathering. And like I said earlier on, if you see one aspect of menopause, ask for the other three aspects, because that's your robust data gathering. As doctors, as GPs, we're not treating clinical problem, we are treating the situation and the patient. So if you don't get to know the patient and know what's going on in their life, you will just have what I call tunnel vision and consultation, just focused only on that clinical problem. But we want to get you to build your expertise and your competency and manage patients in holistic with holistic care. A clear pass candidate will also think about treatment options. That has to also include lifestyle options. So like we've given the feedback, moisturizers, lubricants, talk about the medication. Does this patient need bloods? Because if she's coming and saying, doctor, I've got hot flushes and other things, and you're picking up that her routine bloods haven't yet been done, you might want to also be checking them and doing a urine dig, because with GUS symptoms, she's most likely having urgency, and we want to make sure that there is no UTI there. Cases like this usually come heavy with PSO history. Might be relationship at home is being affected, or the patient might be irritable and it's affecting relationship with the kids, family well-being is being affected, or even as far as relationship with her colleagues and how she's getting on at work with manager, or she may have gone to disciplinary committee, she may have been irritable and they've called her in for a meeting and she's not telling herself she needs to have this checked or get that medical help. So sometimes asking patients for their motivation, why they are seeking help, what has happened, and what's the journey that has led to that point in time when you see patient, it matters. This is all part of getting to know the patient. I always like to talk about patient medication safety. So patient safety, medication safety. If you are prescribing something for a patient, you've got to think ahead of that case. In your data gathering, think ahead of the case and say, I'm going to prescribe this medication for this patient, most likely offer it. Will it be safe for that patient? So if you know what the medication you are thinking about, you've got to also think, okay, do I need to do a BP check in this case before? Do I need to check for red flags in that case? And as part of the clinical management, also explain some of the things to watch out for and side effects. Cases like this, and this is where we come in with the health literacy and communication skills. Some patients may come in with no ideas and they want to know, but they may have an idea, but they want to know the reasoning behind it. So they may, in the back of their mind, and what we discussed in the previous masterclass on ClearPass Clinical Management, we talked about the Ask Me 3 questions. Patients want to know what's happening. Why me? Why is this happening? What are we going to do next? So why does this need to be treated? And that's one of the things we need to be communicating to have robust clinical explanation to the patient. And of course, in this case, Dr. Chogo has mentioned it, what's your follow-up plan with these patients? Are you going to see her in 1 week time? Or if you're doing a telephone consultation, do you need to be bringing her into the GP practice to check her blood pressure, her weight, and to do blood? So that may be a shorter follow-up. But if it's a case where you need to manage the patient over the telephone and all these things have been done, then you've got to discuss that your follow-up will be to see the patient in XX weeks' time, so that you can review and see how she's getting on with the medication and if there are any improvement. And with this exam, the examiners want to know what is your step 2, your step 3, step 4. So if you discuss follow-up and you see the patient and the medication is not working, what are your options there? So I might say, well, I'm happy to see you in clinic in 4 weeks' time. Let's catch up and see how you're getting on with the medication. If the medication has worked for you, I'm happy to put it on repeat, and then we can continue the dose and you can book your follow-up with our practice nurse just to check and see you're getting okay. But if I see you in 4 weeks' time and the medication hasn't worked well, we can then discuss increasing the dose of A, B, and C and X, Y, Z. So examiners want to know your step 2, your step 3, if that immediate plan is not working well. And this is the difference between what we do here and in clinic practice. In clinic, we know these things, it's in our mind, but the examiner is not here. So in clinic, when you see a patient, you will tell a patient, oh, if I see you next week, it's not working. Oh, sorry, we see a patient and we say, oh, I'm going to see you next week so that we can catch up on this, and then we'll talk about what needs to be done next. And that may be okay for you alone in clinic with the patient. Not the best, but you know what information you have here. But the exam is not in your mind, and they want to know, or they want to see that you know your stuff. So the best examination tactic in such cases is to state your step 2, step 3. When I see you in clinic, if A, B, and C hasn't worked, then you state what you need to do next. So that's an exam tip for you right there. That's your exam tip right there. So one of the last comments before we move on to the next case is you will also need to let patients know how long to expect improvement. So Dr. Chogo has put that in the comment. Usually it takes 3 months after commencing vaginal estrogen. And this is managing expectation of patients. In out of hours, I've seen that several times. Patient will come and say, oh, doctor, my GP prescribed me medication last week. What's the medication? Sertraline. I'm not feeling better. And I'm like, literally. But then I have to take the time to explain to the patient that this is how long it takes. Please be patient. And some of them are frustrated already, calling you at 11 o'clock because they just don't feel well. And they don't, because the GP hasn't taken that time to walk them through what to expect. I'm having to deal with it at 11 o'clock at night. So just a bit of a joke there. And I hope if you are in my area, region-wise, you are learning and using the right practice so that you don't bring work for me at 11 o'clock. So best practice, everyone. We try and teach you the best. Manage patients' expectation about how long it takes for the medication to get better, especially when you know you need time. I've seen patients even come and say, oh, my doctor gave me antibiotics yesterday. I'm here today and I'm still not better. But when I do my red flags, there is no red flag. Nothing has changed, but they are just not better. And when you ask them, what's the motivation? Like, oh, I've got a trip tomorrow and I want to be better about tomorrow. These things happen in real life. And what we try and get you to see is that, okay, if you build the right skills and the right competency, you'll be able to function as a doctor in life and you build that career and not have complaints or problems with patients. Another question and statement in the chat as well is that menopause consultation is a good time to do opportunistic health promotion. Absolutely. So it's not just enough to say, oh, there are some lifestyle things that makes us unwell. What's the purpose of asking those lifestyle things? Smoking, alcohol, stress. If you're picking up the patient has a stressful work or has not slept, does that patient need sick notes? Does she need that extra counseling support? Does she need to speak to, if you have a nurse in your practice, so depending on where you are, if she has a nurse in a practice and the nurse is not with special interest in menopause, then can she go in for that extra well-being support? There are some parenting hubs that have parent classes in the community to talk about things like this, just checking for people, for ladies to talk about what they're going through and just get that group support. Somebody else is going through it, what they have tried, they hear it and they go and try it as well. So we encourage you to think about the robust clinical management when managing cases like this, including spicy food as well, because we know spicy food can trigger hot flushes. If you're picking up that the patient is obese, a lot of alcohol, you can either relate that, as part of your explanation in the immediate case and managing health promotion. But the extra thing I will add to that is be mindful of your time and know when to benchmark certain things for your next consultation. So if I'm seeing a patient who is obese, and is not the priority of the consultation immediately, towards the end, as part of my health promotion, I may then want to talk about the weight management, but you can manage that when you already have 9 minutes, 34 seconds left, and you still have to do safety netting and patient information leaflet. So what I might do is benchmark it for another consultation. I might say, we've checked your weight and I noticed in the records that your BMI is raised. Please do not use the word obese to patients. as a medical assessor, we don't even write obese in our report, because weight is a very sensitive topic and people are offended by it. Even writing the raised BMI can cause offense if they understand, but it's less offensive than saying, because you are obese, you would lose, your IPS just goes down the drain. So use words like, I noticed in your record that you have a raised BMI, and I would like to see you in another clinic so that we can talk about ways we can support you to lose weight. Would you be happy to come see me in clinic? So know when to benchmark certain things. And in that clinic, you then again follow the same tactic. Talk to them about what you be doing in that clinic. Examiner want to know your step 2, step 3. When I see you in clinic, we can talk about the ways we can support you. We can probably also do your bloods. As part of the bloods, we check that your bloods for thyroid, and I can let you know what the results are. And A, B, and C, and X, Y, Z that you're going to do in that discussion. So that's the extra things that I can do in this case to make it holistic. Thank you, everyone, for listening to this feedback. We are going to now move on to the next case and do and learn together as a community.